Okay, we'll discuss non-invasive NAV in the clinic, in particular our own data. This is my conflict of interest. We got the catheters for this study from McKay. Well, we all know intolerance is a risk factor for non-invasive ventilation, and well, we have heard in the introduction talk that asynchrony is very common in non-invasive ventilation. That's also shown in this data by Joliet. This is a heterogeneous group of patients on non-invasive ventilation, and what they actually show is that in 15% of the patients in non-invasive ventilation there's auto-triggering, there's ineffective triggering and late cycling off in 8% of the patients, and premature cycling in 32% of the patients. Asynchrony has to do with leak in pressure support ventilation. These are data by Cinderby and Beck, and they nicely show that when you increase the amount of leak during non-invasive ventilation, asynchrony, and in particular right here, wasted efforts, increase significantly. So just to show you a case before I start out with our study, this was the reason that we started out with the study basically. This is a 65-year-old man with COPD, congestive heart failure, and he was admitted to our ICU because of progressive dyspnea and hypercapnic acidosis. Right here, the slides are not very easy to see, but you recognize it. This is on pressure support ventilation, 10 of pressure support, 8 of PEEP, and we tried all different kind of settings, but basically the same happened all again. Right here, of course, the EDI. What you can see here, there are more and more wasted efforts. Right here, wasted efforts, it basically goes into backup ventilation. More wasted efforts, reduction in minute ventilation. More wasted efforts. This looks terrible, and you can trust me, this was done by an experienced clinician. He tried everything, increased pressure support, decreased, increased PEEP, decreased PEEP, but he couldn't get it better than that. And then we switched to NAVA, and this is just an example, of course. We switched to NAVA, and there was an adequate minute ventilation again, and the patient was doing well. So this one triggered us to do this study, basically. So, what did we want to look for? It's a small study, and I'm going to show you, well, data from the ongoing study. It's preliminary data. But what we wanted to find out if indeed NIV NAVA does improve synchrony compared to pressure support, and whether the patients have benefit of it. Do they feel more comfortable? We had all patients with a past medical history of COPD. They didn't have to be admitted because of acute exacerbation of COPD, but they did have a past medical history of COPD. There was a clinical indication for non-invasive ventilation, and they had to be stable at the time of entrance of the study. So hemodynamically and respiratory stable. And this is basically the protocol, or actually I'm going to only show part of the protocol. This is how they were randomized. It's either BiPAP vision pressure support, because we wanted to compare two different ventilators as well. It's a servo-I pressure support or the servo-I on NAVA. And each of these modes was for 30 minutes. The level of support on the BiPAP vision was actually the level of support that was chosen by the clinician. Then the level of NAVA was titrated based on the overlay window, and we took blood gases 30 minutes after each mode. We asked dyspnea scores at several time intervals, and we also did a study with different interfaces, but we don't have the data ready to present yet, so I'm not going to show you that. These are the patients. It's only 10 patients, ongoing study, 64 years of age. 2 of them had COPD. These are the other reasons for admission, and 3 of the patients were on vasopressors. This is basically the ventilator settings. Settings is 0.5 on average, not different between groups. 7 of pressure support, 7 of pressure support in servo-I, of course, and 0.7 of NAVA level. Respiratory rate, a little bit higher on the NAVA. And we had a technical problem here, I'll come back to that later. And no, well, at least not significant difference, but in a small group between entitled volume. Of course, no difference in PEEP, that was the setting, and no difference in oxygenation. And this is interesting for later, the EDI max was, well, significantly lower with BiPAP vision pressure support compared to the other modes. So this is blood gases. You should see there's not This was on average on day 1 or 2 of non-invasive ventilation. No hypercapnic acidosis anymore, compensation, and there's no differences in oxygenation. This is quite surprising for us. There was no difference in dyspnea score, but I want you to remember that these patients, based on the EDI, seem to be a little bit more unloaded. So this is the BiPAP, this is the NAVA, this is pressure support on servo I. This is a typical trace of a patient on pressure support with the servo I, and then switched to NAVA. And you can see immediately an improvement in synchrony. And you've seen these graphs a couple of times during this conference. And again, this is the BiPAP, this is non-invasive NAVA, this is non-invasive pressure support. The x-axis shows you the cycle-off delay. This is the early triggering trigger delay. We discussed that extensively yesterday. But in this representative graph, and they basically look all the same, there is a better synchrony right here. You can see it very nicely visualized. And here, this is the summary in the pie graphs again. You've seen these a couple of times as well. BiPAP, BiPAP pressure support NAVA, looking at the total time in synchrony, significantly better in the group of NAVA compared to the other groups. Number of dyssynchronies, same thing basically, and wasted efforts right here, that's 12%, 16%, and it's only 3% right here. So there is a significant difference in the number of asynchronies with NAVA. Is this important? Well, that's an important question, but I'm not sure I really can answer it. But this is, I think that all clinicians in this room will recognize. This is a pressure ulcus on the nose of a patient, and we all know why that's happening. Because there's leak. And when there's leak, the patient is in asynchrony during pressure support. So what we typically do is try to put the interface with more pressure on the face. And this is the final result. You cannot see it very good here, but there's a pressure ulcus right here. And again, I've shown you this picture. This is the reason why we do it. We try to reduce leak to reduce asynchrony. But that's not an issue anymore. If we have NAVA, that's not going to be the outcome of this study. But as clinicians, we will think that this is important. Because what we basically can do is switch between the different interfaces. This is the interface we typically use. But we could switch between other interfaces just to prevent decubitus in the face. And that might be an important outcome parameter for future studies, for larger studies. So I think to conclude in this study, yes, NIV NAVA in our preliminary data has shown to improve patient ventilator synchrony, but it didn't affect blood gases and it didn't affect dyspnea sensation. But there are some limitations. Of course, these are preliminary data, but more importantly, I think looking back, we were a little bit too late. We should have included these patients the moment they got in. I mean, that's the moment you have the most asynchrony, when there is the respiratory acidosis. So I guess we were a little bit too late. And of course, for comfort, 30 minutes is probably too short. You need a prolonged period of time to really score comfort. Okay, that's it.
Thank you very much.